Welcome to LGBTQ Mental Health and Addiction presented by Dr. Petros Levounis. This is the last presentation in the virtual Community Opioid Symposium. This free educational event is brought to you by the Louisiana Department of Health, Office of Behavioral Health, Acadiana Area Human Services District, and Women's Foundation. The purpose of the Community Opioid Symposium is to increase awareness and education for prevention and treatment of opioid use, misuse, and abuse. Thank you all for attending these educational presentations. This session is accredited for 1 hour for the following: social worker, general credit, licensed professional counselors, addiction specialist, AMA, PRA, category 1 credit, and psychologist. Full participation is required to receive credit and will be monitored throughout the session. After the event, you'll receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Dr. Petros Levounis has no financial disclosures. None of the members of the symposium's planning committee have any financial disclosures. Petros Levounis serves as professor and chair of the Department of Psychiatry at Rutgers, New Jersey Medical School and chief of service at University Hospital in Newark, New Jersey. Dr. Levounis came to Rutgers from Columbia University, where he served as director of the Addiction Institute of New York. Dr. Levounis is a Phi Beta Kappa graduate of Stanford University, where he studied chemistry and biophysics before receiving his medical education at Stanford University School of Medicine and the Medical College of Pennsylvania. In 1994, he moved to New York City to train in psychiatry at the New York State Psychiatric Institute of Columbia University. He graduated from Columbia, earning the National Institute of Mental Health Outstanding Resident Award, and went on to complete his fellowship in addiction psychiatry at New York University. He is a Betty Ford Scholar, a member of the Laughlin Fellow of the American College of Psychiatrists, and a recipient of the 2008 Coalition Leadership Award, the Irma Bland Award for Excellence in Teaching Residents, the Nancy Rosk Award for Excellence in Medical Student Education, and the U.S. State Department Speaker and Specialist Award, and the Association of Gay and Lesbian Psychiatrists Distinguished Service Award. Dr. Levounis has served on the boards of the American Society of Addiction Medicine and the American Board of Addiction Medicine. And from 2005 to 2009, chaired the National Committee on Addiction Treatment of the American Psychiatric Association. Dr. Levounis is a Betty Ford Scholar, a recipient of the U.S. State Department Speaker and Specialist Award, a Distinguished Fellow of the APA and ASAM, and an honorary member of the World Psychiatric Association. Dr. Levounis has published 13 books, including the self-help paperback, Sober Siblings, How to Help Your Alcoholic Brother or Sister and Not Lose Yourself, the textbook of substance dependence and co-occurring psychiatric disorders, motivational interviewing for clinical practice, the behavioral addictions, becoming mindful, and the office-based buprenorphine. Thank you. Treatment of opioid use disorder, now in its 2nd edition. Dr. Levounis is currently working on a pocket guide to LGBTQ mental health and the first textbook of technological addictions. Several of his books have been translated into French, German, Hungarian, Japanese, Portuguese, and Spanish. And I'm so sorry that I'm not a clinician for mispronouncing that, but we are very, very honored and glad to have you, Dr. Levounis.
Okay, thank you so much, Amy. And hello, everyone. And I'm very honored to be invited back. I was in person at your program about a year ago, and I'm really delighted that I have an opportunity to discuss another topic today. So let me share my screen here, and we'll take it from there. So today's Today's topic is LGBTQ mental health and addiction. I don't have any conflicts of interest. And the way we're going to do this today is we're going to cover 7 topics. They're not necessarily closely related, but they do cover the area of LGBTQ mental health and addiction. And I certainly hope that we'll have enough time for a conversation at the end. So let me go through some ideas that we have about 2020 LGBTQ mental health and addiction, and open it up for discussion. All right, let's start with the closets. Why do LGBTQ people need to be in a closet to begin with? Primarily because of discrimination. This is 2013 data and do show how LGBTQ people get discriminated against on all kinds of different elements of society. To me, probably one of the most disappointing ones is the one that says being made to feel unwelcome at a place of worship. Here you have a church, synagogue, or mosque that is supposed to be open to everyone, and yet 30% of LGBTQ people have felt discriminated against. Now, as bad as things are in terms of discrimination against LGBTQ people, the general idea is that every year that passes, we're getting better and better, that society is moving in the right direction, and therefore, pretty soon we'll have no longer discrimination against the LGBTQ people. Well, not so fast. This is data, what you have in front of you are data that compare discrimination between 2016 and 2017. And along the variables that you see here, things are getting worse. For example, in 2016, 28% of non-LGBTQ Americans were uncomfortable with the idea of having an LGBTQ doctor. And in 2017, that increased to 31% of non-gay Americans feeling uncomfortable with an LGBTQ doctor. So a lot of work to be done, and in some ways we may be going backwards instead of forwards. Forward. Okay, in terms of coming out, these are the mean ages. Boys come out a little earlier than girls. Men, in general, on average, come out around the age of 18. Women, the age of 21. And bisexuals somewhere in between the two. All right. When we think about the coming out process, first of all, it's one of the most unique aspects of LGBTQ mental health. As we're going to find out a little later, the majority of LGBTQ mental health is pretty much identical between straights and gays. But the coming out process is unique to us who are LGBTQ. And here's one path of coming out. First, realizing that there's something different about yourself, then coming out to yourself, coming out to friends, then family. Siblings are the most underappreciated ally in our work in mental health. It's true of addiction, it's true of depression, it's true of people coming out. Siblings, brothers and sisters, very often are some of our very, very best allies. And then coming out to co-workers, and of course the final frontier in 2020, the social network, where all of us kind of are basically live these days. Now, this is not as unidirectional as it shows on this slide. Very often somebody starts coming out, they open up at a place of work and they get dinked. Somebody is not quite as appreciative or open-minded or accepting as they would like. So they go back in the closet and then they come out a little later. So there is a back and forth and very often an iterative process in coming out. All right, so for each one of these 7 chunks that I'm going to be covering today, I have some clinical tips at the end. The majority of people in the audience today are practicing clinicians, so that's why I brought in some tips for each one of these 7 chapters. So what do we do for our patients who are coming out? Offer validation, provide a safe, welcoming, affirming, and celebrating environment. Not long time ago would say the best attitude towards LGBTQ people is tolerance. Well, that's not enough in 2020. We just don't just tolerate people. We go a step further. We welcome people and we affirm their sexuality and we celebrate their community. This being said, we also want to respect patient autonomy. Very often, we as clinicians are a little more rah-rah-rah about our patient coming out than our patient may be ready to do so. So say, okay, you're gay, fantastic. When are you coming out to your parents? When are you coming out to your coworkers? Come on, let's do it, go, go, go. The patient may not really be so ready for this. So scale down some of this and allow the patient to have her or his autonomy. Finally, the issue of making a mistake. Some of our residents and some of our medical students here in the medical school very often freeze in front of LGBTQ patients. They mean well, but they're so afraid that they may make a mistake. Maybe they will use the wrong pronoun. Maybe they will ask something that is not politically correct. And so they default to not asking the question at all. And the mantra is, don't do that. Just ask the question, engage with your patient. And if you really come from a place of warmth and curiosity about the patient's life, you're fine, you'll do okay. What if the question that you ask is not the most 2020 politically correct one? So be it, who cares? You came from a place of warmth and curiosity. Let me bring you an example here. And it's totally true story. My husband comes in to our university here to get his medical care. And so he gets to meet his doctor, and in the course of the conversation, my husband says, you know, my husband, Petros Levounis, also works here, and he is chair of the Department of Psychiatry. At which point the doctor says, oh yeah, of course, I know him, that's great, yeah. And then the doctor stops and says to my husband, so you're gay? And my husband says, yes, of course I'm gay. And then the doctor asks, oh, okay, so who's the man, who's the woman in the relationship? I mean, you can immediately appreciate how outdated and wrong that kind of question is, who's the man, who's the woman in a gay relationship. But at the same time, the doctor was coming from a place of warmth and curiosity. She was interested in finding out more about our lives. So be it. What if the question is a little awkward? Doesn't really matter. What matters is that she wanted to find out about our lives. All right, let's move on. Speaking of some of the terminology, this whole idea of gender and sexuality not being dichotomous really was introduced by Alfred Kinsey a long time ago in the 50s, in the 40s, late 40s and early 50s, 1940s, 1950s, with this groundbreaking work. Most of you have seen the Kinsey scale that essentially tells that we do have some people who are exclusively heterosexual, some people who are exclusively homosexual, but we also have everything in between, the Kinsey scale. And that's where the world that we live in right now. Let me just stop here and spend some time on this particular slide. First of all, sexual orientation and gender, two different concepts, two different facets of our humanity. Sexual orientation, mostly how we relate sexually with other human beings. Gender, more of an individual concept about how we see ourselves. Sexual orientation breaks down in three different components. Sexual orientation identity. Do I see myself as straight, gay, bisexual, asexual? How do I see myself? Sexual orientation behavior, which is a little different, which is whom do I sleep with? Do I sleep with men, women, both, neither? And then there is sexual orientation attraction, which is a more internal experience of whom I really kind of feel mostly attracted to. And that has a dimensional component to it, very much along the lines of a Kinsey scale. It's a little more difficult to pinpoint down the sexual orientation attraction. Very often we approximate it through an investigation of dreaming, of masturbation, of things of that sort with our patients. Very often sexual orientation, identity, behavior, and attraction are congruent in a traditional sense, but as you very well know, quite often they are not. We do know men who identify themselves as straight. Behaviorally, they sleep with both men and women. And when you look more closely to the sexual orientation attraction, they end up being more on the homosexual side than the heterosexual side. Somewhat similarly, gender also breaks down in three components. There's gender identity. Do I see myself as a man or as a woman, as gender queer, queer fluid, gender fluid? There is gender expression. And I want to make sure that you remember that. Gender expression has to do with the way that people walk and talk and dress and essentially present themselves to the outside world. And you can have gender expression that is particularly masculine or particularly feminine or androgynous. Androgynous from the Greek, from man and woman, being somewhere in between. And that's gender expression. And finally, there is sex, which is probably the most dichotomous one out of all these variables. And that is your chromosomal makeup. Are you XX or XY? The vast majority of people are either XX or XY. They are women or men from a sex perspective. And there are very few people who are intersex, who are chromosomally. They may be XXY or some other variants that are pretty rare. And therefore they end up, genetically speaking, being intersex. All right, and these are all kinds of different words that describe the people's sexual orientation and gender. You may have seen most of them. I have a glossary at the end of my slides. Anybody can use my slides. There's nothing proprietary about any of them. So I do have a lexicon at the end of this, so you can actually get the exact definition of each one of these words. Queer is an umbrella term that covers a lot of people who may not be traditionally heterosexual and cisgender. Gray sexual, people who are somewhat asexual, but they do have sex every once in a while, but they're not particularly interested in it. Aromantic, people who are not only not interested in sex, but are actually not interested in any kind of romantic relationships either. Polyamorous, being having sexual partners, several sexual partners at the same time. Cisgender, the opposite of transgender, where the gender assigned at birth is the same as the gender of that the person identifies with. That's cisgender. And of course, allies. And I certainly hope that anyone on this audience who doesn't happen to be LGBTQ is an ally. All right. Some clinical tips. Make sure you use gender neutral language so that you don't assume that the sexual and romantic partners of your patients are all heterosexual. They is the most, the preferred way of using gender neutral pronouns. It's a little awkward because you use they with singular. They plays the piano. And for people who have been, you know, zapped while learning English, especially as English is a second language, it's particularly cringe-worthy, but just try it out and see if that helps you. Update your intake forms so that you do have preferred names and pronouns, and just also appreciate that both gender and sexual orientation may change during the person's lifespan. It's a controversial topic in this area, whether women have more fluid sexuality than men. A lot of people, including myself, do believe that women are more flexible sexually than men in general. But there are other people who say this is yet another political construct, another societal restraint that we have come up with, another sexist attitude that by saying that women may have more flexible sexuality, once again, we're putting women down, implying that they do not have as strong sexuality as men. It's a valid argument. I've read about it a lot. I've heard about it. I've debated it. But I still, at the end of the day, do feel that women have more fluidity in their sexuality than men. But very controversial issue in our field. All right, moving along to mental health and suicide. Three areas of the minority stress theory of why we have increased rates of mental health among LGBTQ people. Number one, flat out discrimination. We get discriminated against, we're more stressed, therefore that translates into increased mental health problems. There is also expected or perceived discrimination. So even though we may not be actually be discriminated against, we may be perceiving this kind of discrimination, which also is stressful. And finally, the most sinister part of the minority stress theory, the internalized homophobia. I was brought up, not necessarily me, but LGBTQ people, as feeling that we're evil, or that we're second-class citizens, or that we're not worthy, or that we are somewhat less of human beings than our heterosexual counterparts. And little by little, that seeps in and becomes hating ourselves. Not just other people hating us, but us hating ourselves, which also adds to the minority stress theory and eventually translating into higher rates of mental health problems. Statistics up the wazoo, about 1.5 higher rates among LGBTQ people. Whatever we say today is bigger and actually more alarming for transgender people. Risk of suicide in transgender people in the military, 20 times higher than that in the general veteran population. So no matter how bad things may be for LGBT people, T people have it worse. That's US, by the way. This, don't assume that this is true across the world. For example, in Iran, gays and lesbians are extremely discriminated against, even by law, and there are very harsh punishments for lesbians and gays. On the other hand, transgender people are fully accepted. At some point, the Ayatollah said that it's perfectly fine to be transgender, and then even the state pays for gender-affirming surgeries. So again, not the same across the world. Something for people who work in inpatient settings to remember that, you know, that for some people having some beauty items may be essential to maintain their gender expression in terms of makeup, in terms of hair extensions, and so on, that may not be easily available in inpatient settings, and we need to provide those for them. Be aware that some scriptures and religious documents may be particularly unfriendly to LGBTQ people. So be sure that you balance that at least with some very LGBTQ affirming literature. And also there's the issue of single gender rooms and bathrooms. We no longer have men's rooms and women's rooms. We do have any gender bathrooms, certainly in our building, and we try to pass that as much as possible. All right, so screen people for mental illness because the rates are higher, as we mentioned before. In terms of treatments, both pharmacological treatments and psychosocial treatments are pretty much identical for LGBTQ populations as with the heterosexual populations. And if you happen to be a physician, nurse practitioner, or physician assistant, certainly consider the medical aspects of LGBTQ health. PrEP and PEP have revolutionized the medical treatment of our LGBTQ patients, particularly gay men. Vaccinations for Hep A, Hep B, human papilloma virus vaccinations, and of course hormonal therapies for transgender patients, the medical aspects of LGBTQ medical care. All right, moving along, moving to substance use disorders, my particular area of expertise here. So when I did my fellowship in addiction psychiatry, people thought that gays and lesbians show higher rates of substance use disorders because they used to augment a hyperactive, restless lifestyle and an exaggerated need for self-sufficiency. I mean, where did they get that stuff? So I did a deep dive and I found where they get that stuff. And when you look, you find that in 1977, somebody, Spots and Sons, they extensively studied the psychosocial characteristics of 9 representative cocaine addicts, and they found that these were largely consistent with the clinical descriptions that we just saw before. So all this restless lifestyle and exaggerated need for self-sufficiency, all that stuff is based on 9 interviews with cocaine addicts of 1977. I'm not making it up. This is the entire basis for something that generations of medical students and residents were taught to be the reason for the increased rates of substance use disorders among LGBTQ people. Shaking my head, rolling my eyes. Anyway, so what do we believe today? We do believe in the minority stress theory that we explained before, the discrimination, the perceived or expected discrimination, and the internalized homophobia, plus the issue of self-medication. LGBTQ people under stressful circumstances, they may very well end up self-medicating these underlying psychiatric disorders or psychological stress with the drugs of abuse. All right, here's another one that I want you to remember. I want you to remember the gender expression and the androgynous expression being part of gender expression. Here's something else I want you to remember. All right. When we look at people's sexual attraction, that dimensional fact of sexual attraction, and we plot that against substance use disorders, this is what we find. On the left, we have women. On the right, we have men. The shape of the curve is very similar between the two. So let's just look at, let's look at here for women. On the y-axis, we have a measure of substance use disorders. As it turns out, here in green, we have totally gay, yellow, totally straight, red is bisexual, And then we have these very interesting areas here and here where people are almost gay, but not entirely, or almost straight, but not entirely. As it turns out, people who live in these areas of being almost straight, but not entirely, or almost gay, but not entirely from a sexual attraction perspective, have the highest stress and the highest risk of substance use disorders. It's a fascinating result that we don't fully understand or where to place, but your patients who are living in this dimensional Kinsey-like, not totally 100% gay, straight, or bisexual, may need special attention in terms of the possibility of substance use disorders. All right, I want to elaborate somewhat on crystal methamphetamine, which is an area of interest of mine, and done some work on these matters and how that intersects with LGBTQ mental health. So first of all, this report came out 2 years ago on November 6th of 2018 with a provocative title, While America Wages War on Opioids, Meth Makes Its Comeback. And that's where we are right now. We are on the comeback of crystal methamphetamine. Back in the early 2000s, like 1998, 2000, we started appreciating the connection between crystal methamphetamine use and HIV transmission. A private citizen, Peter Staley, paid for these posters that plastered the gay neighborhoods of New York City with the title, Huge Sale, Buy Crystal, Get HIV Free. So what happens there? You get intoxicated with crystal methamphetamine. Part of the crystal methamphetamine intoxication syndrome is decreased inhibitions and decreased judgment. At the same time, you have increased sensation and sexual arousal. So decreased judgment and inhibitions, increased sexual arousal, boom, unsafe sex guidelines go, safer sex guidelines go out the window. People have unsafe sex, and that results in HIV transmission. Now, this was very true back in the early 2000s. Nowadays, with PrEP, we have an antidote to this basic pathway. We can put our patient on PrEP. So even if they use crystal methamphetamine, which we very much hope that they don't, but if they do, they have the protection of pre-exposure prophylaxis of PrEP. So during that time, around the 2000, 2001, or 1998, 2000, 2001, somewhere there, there was a protective aspect to crystal methamphetamine, because people would get high with crystal meth, and although they would be very excited about having sex, they would also get erectile dysfunction. Crystal dick is a euphemism. It's anything but. What actually happens is when you get high with crystal methamphetamine, you do experience, a lot of people, the majority of people will also experience erectile dysfunction. That's why around that time, the turn of the millennium, the whole idea of who's top, who's bottom became huge in the gay male community, because of course, if you were trying to assume the top position and you were on crystal methamphetamine, you would have much more difficulty doing so. Enter sildenafil and the erectile dysfunction agents around that time. They made their appearance, and therefore there was not an issue with erectile dysfunction. So you could get as much crystal methamphetamine as you want, and at the same time have proper erectile function, which resulted in an increase in HIV transmission. Perry Halkiris did a lot of work on these matters, and this is a complicated study here about anal receptive acts. There are 3 clinical situations here where the person is, the study person is HIV negative, and his partner, which is all about gay men here, is also HIV negative. Here is a clinical situation where the research subject is HIV negative and the partner is HIV positive, and here on the right is a clinical situation where the subject is HIV negative and the partner is HIV unknown, has an HIV unknown status. In each one of these three clinical situations, being on crystal methamphetamine, Tina is a nickname for crystal methamphetamine. Crystal, Christina, Tina. So Tina means crystal methamphetamine. So in each one of these three clinical situations, being on crystal methamphetamine right here increases the condomless sex tremendously. Look at this here. 58% of people who were with an HIV status unknown partner had condomless sex, despite the fact that they were negative and their partner was of an unknown serostatus. So no matter which clinical situation you are in, being on crystal methamphetamine will certainly decrease your judgment and you will end up having much more unsafe sex. Something that seems very straightforward these days, but it was quite revolutionary at the time that Perichalkidis published this data. And where are we today? This is a 2017 map of the United States. Louisiana is pretty much at the cutoff point there, but we do see that essentially we have a huge fentanyl issue on the east side of the country and a huge methamphetamine issue on the west side of the country. It's not blue and red states. We're not talking about presidential politics right now. We're simply talking about crystal meth versus fentanyl. And this is data that came out on September 14th of 2020, just a few days ago, that show that once again, especially with older adults, 26 and older, crystal methamphetamine keeps on going up and up and up. Finally, a couple of words about prevention of crystal meth. This is a campaign that we did on primary prevention. This is when you unleash your campaign to everybody. And that's why it's primary prevention. And it's essentially scare tactics. You put people there who are particularly distressed and therefore you scare people. Quite effective. It was done with tobacco and it was effective. It was done with quite crystal methamphetamine and it was also quite effective. And then we underwent a secondary prevention campaign, and that was a disaster. Secondary prevention addresses people who are already using and promises them, hey, you come to me for treatment and I will make sure that you stop using and you'll go back and you'll be sexy and beautiful and rich and famous and all the wonderful things that are going to be coming your way. Terrible idea, because when you unleash a secondary prevention campaign, and these are some of the ads that we put up on magazines and clubs and everything else, you are also addressing people who have never used crystal meth. And the message to these people is, whoa, I can use all the crystal methamphetamine in the world I want, and if it ever gets too much, no problem, I'll go to the good Dr. Levounis, and Dr. Levounis will make me crystal free and sexy again. Terrible idea. The community was up in arms with our campaign, and of course they were right, and we ended up taking it down. Couple of words about COVID-19. So what we're seeing with COVID-19, a massive increase in virtual sex. Pornhub offered a premium service free for all visitors worldwide for 1 month to contribute to the fight against COVID-19, and it was very, very successful. And as mentioned before, we're now working on technological addictions and cyber sex, which of course has skyrocketed with COVID-19. Cyber sex is an umbrella term that includes online pornography, online dating, sex chat, sex webcams, teledildonics. I'm not sure if everybody knows what that is, but you can pretty much decipher it from its name. They're essentially sexual aids that are controlled virtually by another person who can actually speed it up, slow it down, and do all kinds of fancy things remotely. All that, as you can very well imagine, has skyrocketed over the past 6 months due to COVID-19. So, couple of clinical tips here. Do look for alcohol, marijuana, tobacco among lesbians, stimulants, cannabis, and tobacco among gay men. And if you have a campaign that you want to unleash on your communities, might as well have a couple of, I don't know, focus groups or some, consult your community before you do anything. Wise idea that we learned only a little too late. All right, bringing us up to dating and technology. These are data from 2020 and showed how many of it, 30% of US adults in 2020 are using dating sites and apps. But look at this further down here with straight and LGBTQ people, 28% of straights, while 55% of LGBT people using sites and apps. This is a site, it's a very old one, manhunt.net. You put in what your age, you put down who you are, what you're looking for. The machine does the matching and gives you some possibilities. Very much like Match.com, OkCupid, all these sites that heterosexuals also use. Of course, everything changed with the apps. The apps took the internet sites and made the turbo dating apparatus out of them. Unless you've been living under a rock for the past few years, you must know Grindr, which is a GPS-based app where you can be walking down the street and somebody else is also on Grindr. So you can connect right there and then. You have a profile page. This is the creator of Grindr, Joel. He eventually sold Grindr to a Chinese company, but this is his very own profile. It's a very timid one. There are other ones that, as you can imagine, are far more explicit. This was the original lesbian app, Blender. For some reason, we're not quite sure why, it did not do well among lesbians. And then Blender opened it up to pretty much everybody, and it's now doing quite well. And of course, there is an explosion of dating apps that focus, that cater to specific subpopulations. You can imagine Scruff particularly caters to men with beards and facial and body hair. There are all kinds of body habitus focus of some of these apps. A relatively new trend is gay people using straight apps, and that is more something having to do with people who may be more interested in the romantic side of dating rather than the sexual side. It's a nuance of the social network. And finally, I just want to show you this. This is a picture I took a few months ago in New York City. It is the MTA bus, and there's an ad for a soft drink, and it says, "Your taste buds will always swipe right." A direct reference to dating apps. I just want to make sure that you realize that there is absolutely nothing extreme, nothing outre, nothing kinky particularly, although there are kinky apps, of course, about dating on the internet and using those apps. This is very much part of mainstream in 2020. All right, clinical tips here. To learn about the communities of the patients you serve. Go on Wikipedia, go on the internet, check out some of those sites, and you'll be all that much more, that much smarter treating your patients. And of course, it's no longer acceptable not to know what Grindr is, and you have to be able to be up with the times when it comes to these matters. All right, a couple of words about our own sexuality. This is some work that we did some time ago. In some ways, it goes against the dimensional ideas of sexual orientation and gender that I've been promoting all day today. But so just to make ourselves, to make it a little simpler, gay patient, straight patient, gay clinician, straight clinician, 4 different possibilities there. When there's a discordance between patient and clinician, the general theme of psychotherapy, the general theme of the transference and the rapport has to do with, can we understand and trust each other? This is like a very common theme in treatment when there is a discordance between patient and clinician in terms of their sexuality. But there here are the 2 interesting parts of when we have a gay patient with a gay clinician. And yes, there is a familiarity and there is a rapport and there is some kind of warmth that is pretty much automatic, but it can also lead to blind spots. For example, gay patient comes to see me right here in my office and I say something about coming out. They say, yeah, you know, doc, you know how difficult it is to come out. And it's very easy for me to jump on that bandwagon and say, yeah, yes, of course, I know I'm gay myself. I know, you know, how difficult it is to come out. Meanwhile, my experience with coming out may be dramatically different than my patient's experience with coming out, and we have a missed opportunity here for real understanding of what it was like for my patient to come out. So there's these bright spots that may actually blind us very much along, in a way similar to what the classic blind spots are in psychotherapy. And here, when we have a straight patient with a straight clinician, we may have some blind spots where both the patient and the clinician are a little reluctant to even explore some homoerotic material in a patient's dreaming or any kind of thing that would be outside the very strictly straight psychological makeup of the patient and the therapist. Something that comes up often is how open should we be about our sexuality with our patients. It was a bigger issue some time ago. In 2020, everything is out in the open. If you're going to be seeing a doctor or a clinician or a therapist or anybody, you're going to Google that person anyway. And before you know it, images are going to be coming up, and it's I think it's a losing game to try to preserve your privacy. That's what I think. Other people feel differently. All right, a couple of clinical tips here. Yes, if you happen to be LGBTQ and your patient is a rather young person struggling with issues of identity, there are data to support the idea that it may be a good idea for you to come out to your patient because you're already acting as a role model, but you may be also helping that patient move along in her or his struggle to come out. All right, and finally, just a couple of words about the communities that we live in. More and more US adults are identifying as LGBTQ. This is true across different racial and ethnic groups. The Asian line here seems to be a little flat, but for the most part, it seems that pretty much everybody is going up in self-identifying as lesbian, gay, bisexual, or transgender. However, and this is the last slide of this talk, this has not translated into similar access to medical treatment among different racial groups. And what we see here is about PrEP, pre-exposure prophylaxis, which is absolutely a life-saving intervention for gay men, and it is essentially only a white gay man's treatment, and several of the other racial groups are left behind. So social determinants of health, disparities in health delivery are palpable throughout our medical system, including LGBTQ mental health and addiction. All right, final clinical tips here. Ask about broad systems, ask about support systems very broadly, and include friends and community connections that our patients may have. Some of our patients have been cut off from their families of origin, have been disenfranchised and really disowned sometimes from their biological families. So we look at families of community to support our patients. And of course, celebrate the clinical and cultural uniqueness of LGBTQ people and enjoy helping everyone thrive. That would be my final recommendation, my final clinical tip here. All right, thank you very much for listening to me. I want to thank my co-workers. I think in my introduction, it was said that our pocket guide to LGBTQ mental health was being prepared. Actually, it is out, yay. It took us a little longer than we expected, but these are my co-workers, and we're particularly proud of what we end up putting together. All right, thanks again. And let's now open it up for discussion and questions. So I'm gonna stop sharing and we're gonna be back into our general mode here. So I see some Q&A here. Will these be slides available after the presentation? I feel like they're very helpful. Absolutely, you can have any one of those. Would polyamory be considered behavior? Yes, I would say that it's mostly a behavioral term because it doesn't have much to do with an internal experience of attraction, or it has to do with identity though. So I would say it's both behavior and identity, because polyamorous people, some of them at least, do identify as such. Thank you for including what did not work. Yes, it's not only about rah, 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 we do everything right. It's also the things that we do not do right. I don't think it's okay for my patients to know what my sexuality is. Absolutely, this is a personal decision. Just mind you that most heterosexual people do not hide their sexuality. There are pictures on somebody's desk with the wife and the kids. So, you know, let's not have two standards of how much we express ourselves. Again, the majority of my heterosexual counterparts are quite open about saying my wife this or my husband that. And somebody may actually say that this is not all right. And again, this is very much a personal decision. Absolutely not. Coming out to a young client, again, my experience. This is something that has been somewhat researched, and you can decide how you want about this. But what I certainly will insist on is that the young person does look up to her or his therapist as a role model. So it's an increased responsibility that we have with young people, and then you can decide how you want to go about that. But there's very little you can do to avoid being a role model. How can we get the pocket guide? Amazon.com. I guess this is the promotional aspect of this talk. Yeah, it's pretty much everywhere. The American Psychiatric Association is the publisher of the book. Have there been any studies regarding PrEP and condom use? Has condom use decreased use of being on PrEP, a notion that is now safe? Absolutely. This was the concern with PrEP, that maybe what we're doing now, since nothing is 100%, that PrEP may actually decrease the use of condoms, and it has, okay, here it is, it has decreased the use of condoms, but it has not resulted in increased HIV transmission. Quite the contrary, it has resulted in a significant decrease in HIV transmission. And the CDC, the Centers of Disease Control, which, as you very well know, is not the most progressive, liberal, let's take chances kind of organization, has absolutely fully supported the use of PrEP for sexually active gay men. So this is something that is fully sanctioned by the CDC. Does PrEP refer to condom use? No, 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 no. PrEP is a pill. You take it every day. And if you take it's a pill based on anti-HIV medications, it's the same pill that some people who suffer from HIV disease take as treatment. But you take that, there are two now. There are two PrEP medications. One affects your liver a little bit more, and the other one affects your kidneys a little more. So there are side effects of any medication. Even aspirin has side effects. So there's no free lunch when it comes to medications. There are some downsides to it, but they are grossly outweighed by the positive sides of PrEP. So PrEP is a pill that you take once a day, and that protects you from getting HIV, even if you have unsafe sex, meaning condomless sex in that matter. Any other questions that I may not have addressed here, or any other comments that you may have in your own experience treating LGBTQ patients? All right, we do have 3 more minutes, so I'm going to use 2 of these minutes to just talk about our own research here, which I didn't do. I'm just going to share this for 1 second here. Maybe give me a moment, and I will, let's see here. These are all the things. Some quiz here. Here's our own research that was done with Match.com, and we compare motivation to quit smoking among straight men, gay men, straight women, and lesbians. And this is all among very heavy smokers. So what we found, what we are finding, actually, we haven't published the results yet, is that straight men, straight women, and gay men are about equal in their motivation to quit smoking, while women, lesbians, women seeking women, are considerably less motivated to quit smoking, which does align with other research that show that lesbians in general are more accepting of themselves than straight men, gay men, and straight women. And that can be a good thing or a bad thing. It can be certainly a good thing when you accept your body habitus, no matter what that body habitus is. It may be a bad thing when you accept yourself as a smoker. We wish, that our lesbians would be even more motivated, but it's our responsibility to be aware of that and find ways of extra motivating our lesbian patients to quit smoking. And with that, I'm going to stop sharing again. And I think now we have exhausted our time and my welcome, and sending it back to Amy.
Thank you so much. And you are always welcome. We love you here. This is a great presentation. Hopefully we can get you back again, but thank you so much. Right. We appreciate it. And thank you to all of you, all the participants who logged on today. Thanks for joining us for the Community Opioid Symposium. And we hope you have a great day. Thanks so much.
Thank you. Bye-bye now.
Bye.